The next case-based panel discussion on advanced stage non-small cell lung cancer to be moderated by MVT Krishna Mohan. And let me also invite all the panelists, Dr. Deepak Kopaka, Dr. Shikhar, Dr. Bhavesh Bhai, Dr. Soumya, Dr. Rajesh, Dr. Tushar, and Dr. Asma. So, MVT.
Yeah, over to me. Yes. Thank you. Welcome all the panelists. So we have been listening to several deliberations from morning. So let us consolidate all this with a case-based panel discussion. So what I did is I restricted this panel discussion, case-based panel discussions, to only EGFR mutant lung cancers, because if we include everything, then the whole day may not be enough. So I have a series of a set of 3 cases where we'll try to understand and apply whatever we learned from morning, and I'm restricting this again to EGFR mutant non-small cell lung cancer. And thanks to the ICON committee for giving us the prime time for this panel discussion. So this is the first case. She is a 50-year-old lady. She had some cough and mild exertional breathlessness. She was found to have adenocarcinoma of the right lung, which is limited to the right lung. And so she underwent right middle lobectomy and a lymph node dissection. The pathology report is, thank you. Oh, it's too high, okay. Found to have adenocarcinoma, which is limited to the right lung. So it is T2B, 4.2 centimeters N0, stage 2A. So there was lymphovascular invasion, but pleura were not involved. The EGFR mutation studies show that it's exon 21 L858R positive. So this is the case of the who has come to the OPD. Now, what is your plan for the preferred adjuvant treatment? Can we start with Dr. Asma?
So if there is a EGFR positive, we can start off with EGFR TKIs, osimertinib for this patient, if they are affordable for the treatment. Stage 2.
Anyone? Next, Dr. Tushar.
So adjuvant chemotherapy followed, this adjuvant setting, chemotherapy followed by maintenance. Awesome.
Yeah, so this is the important issue here. It's a T2A. So what would be the benefit of chemotherapy? Just for discussion. And what chemotherapy in case you think?
Adenopamitrexate carboplatin.
Bhavesh sir?
I would go for osimertinib, that is TKI for adjuvant T2 4.5 centimeter and lymph node negative with exon 21, that is L858R. So I would go for direct TKI adjuvant for 3 years.
So the benefit will be less in a tumor size of 4.2 centimeter. With chemotherapy, the hazard ratio come to around something like 0.92 in the last meta-analysis. However, having said that, still I would like to go ahead with the chemotherapy. Regarding the guidelines, the NCCN and the ASCO, there is a dichotomy. NCCN recommends it if there is LVI or say there is a high grade. But the benefit is less. I'll discuss with the patient whether she is keen for chemotherapy. If she is keen for chemotherapy and accepts the risk of the chemotherapy, then probably I'll go ahead with chemotherapy as well as osimertinib.
Perfect.
And again, regarding osimertinib, stage this is early. T size 4.2 centimeter, and but still the benefit is still there even in this particular subset. So I'll discuss again with the patient, and if he's willing for that, I'll go give both chemotherapy as well as osimertinib, and duration will be 3 years.
Shikhar?
So, sir, this lady being only 50 years old, there is no reason not to give adjuvant chemo. Although ADAURA did not mandate adjuvant chemo, but still 60% patients received it. So I would counsel to complete the 4 cycles. The choice would be pemetrexed cisplatin because it was non-inferior to vinorelbine cisplatin in the JPANG trial.
Yes.
After that, all the flaws of the ADAURA trial notwithstanding, still I think it is now here to stay. So 3 years of adjuvant osimertinib, probably even longer, because that is how the practice will evolve over time.
I think, Dr. Rajesh, so regarding chemotherapy, and then would you use EGFR TKI in this setting?
The absolute benefit for stage 2A when compared with stage 3 might be less, but I think we will go ahead with EGFR TKI in the adjuvant setting, even in this setting.
So Dr. Deepak, all three questions for you.
Yeah, so I would agree with most of the panelists. Eventually, it will be a discussion with the patient on adjuvant chemotherapy. And yes, if the patient agrees, and if it's left to me, I would give adjuvant chemotherapy. And factors considered while adding a TKI is EGFR positive, both L858R and exon 19 del. I think osimertinib is recommended, and we would do that in practice, sir. So.
Sure. So is there anybody who thinks the earlier generation TKIs would also be helpful in this setting? Geftinib or erlotinib, if not osimertinib, in the adjuvant setting?
So again, it might show a DFS advantage, but eventually might not really turn to have an overall survival advantage across studies. That has been the case.
Yeah.
So yeah.
So yeah.
So again, we have used geftinib in patients who have advanced, not this kind of patients, but definitely in adjuvant setting, and patient is not able to afford osimertinib. We have had used patients who were like T3N2 and high nodal positivity in a lung cancer patients in adjuvant setting, and patient is not affording osimertinib. After the completion of pembrolizumab cisplatin, we have given geftinib to few patients based on the CITONG trial.
Yeah. So in fact, yeah, if you look at the literature, there have been even randomized trials randomized to chemotherapy itself, vinorelbine platinum versus geftinib and things. But once the adjuvant has come, I think all of us are now preferring to use osimertinib, the later TKIs, rather than going to the and as was told in the previous talk, the overall survival also across the stages, as you can see that of course the benefit is more with more advanced stages, but with Adjura, yes, we are now convinced, and we try to consider. The only point which I wanted to bring out from this discussion is that EGFR exon 19, deletion exon 19 versus L858R. So is there any preference? Like we know that
In the adjuvant, I don't think.
in adjuvant it's not. But of course there is some literature saying that yes, probably exon L858R deletion mutation is the one which you may prefer to add this as compared to. So this is about the adjuvant setting. The chemotherapy, yes, I agree with you. The chemotherapy, the high risk factors are LVI in this case, but in general, chemotherapy we would consider, and then of course osimertinib. So let's quickly go on to the second case. It's more interesting. It's 47-year-old male. He's a non-smoker. He presented to us with symptoms, CNS symptoms, left eye pain and left hemifacial pain and headache. So he initially underwent MRI of the brain, so which showed lesions in the left cerebellar peduncle extending into the pons, and then the left temporo-occipital lobe and cerebellar hemisphere. So these are the representative images where you see that the MR spectroscopy also showing the increased choline-creatine ratio and the lipid peak, and these are the representative images of the lesions. And so with this, he then underwent a whole body PET CT scan, which revealed lung cancer. And he underwent a biopsy from the lung lesion. It is adenocarcinoma. The NGS reveals exon 19 mutation. PDL1 is 0 on the SP263 platform. So what is your immediate treatment plan? We start from Deepak.
Patient has symptomatic brain metastasis, so I would ask for a radiation oncologist opinion, and because there are 3 lesions, if they can do stereotactic ablation of these lesions, would go for that. Is a relatively young patient with no major comorbidities. This is the right population where I would consider the FLORA2 data, chemo plus osimertinib.
So immediate treatment, is there any difference? I think by and large radiation is, yeah, Shikhar.
I think with the exceedingly high intracranial response rates with osimertinib, I would probably try a trial of steroids and just put him on osimertinib concurrently. Why to give the toxicity of radiation? Because this patient will be is a young patient, so probably, and we know osimertinib does do very well, and exon 19 is highly sensitive to osimertinib.
I think it's he's symptomatic. The patient is symptomatic for the brain mets. Plus, all these lesions are probably amenable to SRS, so may not require a whole brain radiation at all. So I think radiation should be offered to us.
So any difference in the first management system?
No, sir. Radiation is
Radiation.
Radiation
So what about the systemic treatment options? Is it osimertinib alone, osimertinib chemotherapy, geftinib chemotherapy? or any other oral TKIs or erlotinib plus anti-VEGF?
I think with the availability of the FLARA2, we'll go with osimertinib and chemotherapy because he's relatively young male, so he might tolerate chemotherapy. Yeah.
So you are selecting that because probably the patient has brain metastasis. So what is your practice if the patient did not have brain metastasis?
No brain mets, I would maybe prefer single agent osimertinib rather than a combination. Exon 19 being the
Exon 19, our practice is osimertinib, sir. We do the last option. I think very few do the last option, but we do the ramucirumab erlotinib in patients with exon 21 L858R population without brain metastasis. But if patient has brain metastasis, the regimen has completely changed towards the FLARA2, if young and fit.
If there is no brain met, then it may be some other metastasis.
Like it's a metastatic disease. It's not, we are not discussing a single tumor in the lung.
No, it's a stage 4 lung without brain metastasis.
Okay.
So in that case, would you still use single agent or are you convinced now with the osimertinib plus chemotherapy?
So the osimertinib is definitely an option after the completion of radiation. And regarding the FLARA2 data, again it shows that it is very good PFS with especially in the intracranial population. However, FLARA2 has its own issues with lack of OS. We don't have a overall survival. We can and also the second problem is that the discontinuation rates. There are high discontinuation rates. The tolerance issues were too much. Only 25% of the patients could continue pemetrexed. Around 70% did not continue the maintenance pemetrexed. So the discontinuation rates and the tolerance issue is a major point in FLARA2. And we don't have a OS. Again, the PFS2 is also not very great. So the results are not mature for the PFS2 and the OS. So that's still now an issue for the patients with if we fall back on the FLARA2.
Yeah. How is it?
I will go for osimertinib plus chemotherapy.
So in general, in patients with EGFR mutant lung cancer stage 4, so what do you think, how many of you, what is your experience with the combination chemotherapy with Gefnib? You might have started after the TMH this thing, before the osimertinib thing. There must be some experience with Gefnib chemotherapy. What do you think is the feasibility of that and how many patients are able to complete and what are the results which we are seeing it?
With combination chemotherapy with gefitinib, we face a lot of side effects. Chemotherapy causing neutropenia, even adding gefitinib causing like loose motions. Patients usually come with loose motions, rash. So patient will not continue with the combination. Either we drop out the gefitinib and continue chemotherapy. We do that way.
I don't know. So does everybody has the same experience, or Dr. Tushar, you have?
I think side effect wise, yes, but I think the most approach when it comes to finance and other things, yes, chemo plus gefitinib is being used more extensively now with the data that has come up. But given the choice, osimertinib first as a single agent drug.
Practically speaking, I think we'll adjust the chemotherapy dose to manage the side effects. So we want to give the benefit of combining chemotherapy with the TKI with liberal reduction of doses in the chemotherapy. Yeah.
I think, yeah, but so the other side, so we are looking at the side effect side, but what about the responses side? Actually, see, in my experience, I am very happy with the responses.
Patients are there on this treatment for a very long time. So Gef plus chemo is a good regimen per se. Only thing is patients should not have baseline brain metastasis. Patients with baseline brain metastasis did not fare well.
So if you look the FLARA2 also, the response rates are not much of difference. It is the PFS which is making a difference, and we don't have a PFS2 and the OS data, but responses are pretty similar with the osimertinib and a chemo plus a osimertinib.
So is anybody currently using osimertinib plus chemotherapy? Any experience on that? Yeah.
So I started for a young patient with more or less similar presentation. He's doing well, sir. Now it's like 6 months into the treatment, tolerating well. So he's a 39-year-old teacher. So he's doing really well.
Tushar, as you have?
With osimertinib combination, patients are doing very well, sir. I am not facing any problem with osimertinib.
Yeah, so I think it's an initial experience which makes us scarier, because I too started, but the second patient, I thought she had ILD, developed ILD, but then we evaluated, she had a massive pulmonary embolism, and we lost her recently, day before yesterday. So it's okay, it's good, but then I think we have to be more used to the side managing these side effects and all. So this, if you look at the data, this is what Dr. Satya was also showed. So we have a lot of data, a combination TKIs, the gap brain, the NEJ, the TMA study, and then the FLORA2, and we clearly see the PFS benefits as shown here, PFS benefits and the hazard ratios. The PFS benefits and the hazard ratios are quite impressive, but as all of you pointed out, the toxicity is what has to be balanced, and then we have to move forward. And not only that, as in the index patient case 2, because he already had the brain metastasis, we are happy with this data, of course, and we think and we believe that this will be a manageable problem in clinical practice going ahead in future. And so about coming back to our patient, so he was started.
Symptomatic patients in high tumor burden, would this be a reasonable approach of combining OC plus chemo?
Can you take that question?
So again, the responses are pretty similar. Osimertinib also equally efficacious, and this was not meant for to address that issue that patients who are having high tumor burden, and it was meant for giving a good PFS, which was the primary endpoint. It was never the response rates. So response rates in the FLORA2 was not very much different, and osimertinib itself has got a very good high potency that can give a good responses even in a high tumor setting. The problem is with the grade 3 and grade 4 adverse event, which in FLORA2 was around 60%, and the discontinuation rate was around 40%. So that's one we have to, until and unless we compromise on the doses and drug interruptions and all those things we do, and then we don't know what's the PFS in that setting. So we have to be really careful before and counseling the patients about the adverse event.
Sure. So coming back to our patient, so he after radiation therapy, he was yes.
Before FLORA2, we have seen that our EGFR positive patients who have been investigated on hotspot, some of the patients did worse to osimertinib. When we did an extended NGS, there were some coexisting mutations, and these patients were younger. So by adding carboplatin and pemetrexed, are we covering those extra TP53 and extra? One question is this, and second question is that by adding osimertinib and pemetrexed carboplatin, so failures of these patients, when they will progress ultimately after 3 years or 4 years, then what should be the regime? It is that ABCP, which is still not the standard, that is the only thing. So what would be the standard second line therapy if we use upfront osimertinib pem carbo?
So the first question, yeah. Correct. So are you targeting the other mutations which can possibly coexist? Can we think in those
Probably
ways?
there is no systematic analysis, but yes, TP53 would contribute to resistance over a period of time. And
so the resistance patterns, both post osimertinib and post
we'll come to
chemo
that,
plus osimertinib, both has been demonstrated. They are almost very similar. So post osimertinib and post this FLORA2 design, the mutations that we are getting are almost pretty similar. The MET and the HER2 and the other pathways, they are almost very similar. Regarding whether we are covering the T53 or the other mutations through the chemo plus osimertinib, we are not very sure about that part. That's why the PFS is there.
It is possible. It is possible.
It is possible. They have given that pemetrexed plus osimertinib having a synergistic effect also. But right now we are not sure that whether the post osimertinib, if we give a pem carbo, we might still get an extra 3 to 4 months, which we might not get. So what are the post progression in the FLORA2? What was the treatment that was given? So that part is also very important. And patients did receive chemotherapy.
Wide variety of treatments were given in FLORA2 post progression, including chemotherapy and others. So.
Yeah.
Deepak, you have any comment?
The PFS2 is still not there.
One thing that is very clear, at least in those patients who progress on single agent osimertinib quite early, are patients with brain metastasis with exon 21 L858R mutations. So I think the FLORA2 is clear that at least that difference 19 versus 21 probably is negated with the addition of chemotherapy. Now that's something that we can very clearly understand from the study, but P53, I think the study did not actually at least dwell into that detail. Now what do we do post progression on chemo plus osimertinib? Now actually after the Mariposa 2 data came, I think that regimen would not fit either post Flora 2 or post the Mariposa 1 regimens that if we use them in the first line. I think Mariposa 2 probably might not be an answer, but Chrysalis study which evaluated the benefit of amivantamab post progression on EGFR therapies in MET positive and patients still harboring the EGFR pathways might be the way forward. I think amivantamab might be the drug in that space, but we really don't have great phase 3 data like the Mariposa 2 in that space.
So yes, that's what my next slide is about. So he was started on osimertinib along with pemetrexed platinum, and then he responded for about 26 months, and then he progressed in the lung and liver. CNS remains stable. So what would you do next?
So we'll go ahead with the biopsy, rebiopsy of the lesion.
Correct.
And check for the mutations, further mutations.
So biopsy is done, it's still adenocarcinoma, there are no new targets. So this is what the typical situation arises when we use both osimertinib and chemotherapy, because we don't have clear answers. And I think this is
one point here is it oligometastatic, oligoprogression that's happening in lung and liver? If there are oligoprogressive lesions, I think ablating that would again give us some 3 to 6 months additional PFS advantage. That is something that we need to consider in these patients. If it's a florid progression, I think chemotherapy again.
So you mean SBRT and then continue with the same?
Oligoprogression and continue the same regimen. If oligoprogression.
Good option. Yeah, anything?
Frank progression in the lungs and the liver. So this is not a oligoprogression. So post osimertinib exposure, you can again go ahead with amivantamab plus chemotherapy if that is a patient is affording that.
So this is what at least all of us, we think we know that when the disease progresses on osimertinib and things like that, it could be an on target or off target, and then the change of histology, all these things have been mentioned. So, at progression, do all of you do a biopsy from the tissue, or are you okay with doing the liquid biopsy and then tissue biopsy is more important? And as this is another very important drug which I think in today's discussion I didn't see much of this, is amivantamab. So amivantamab, so this is Mariposa 2, as Deepak rightly pointed out. This patient doesn't fit into this inclusion criteria, but yes, amivantamab is one which is important if we have used only osimertinib, post osimertinib progression, and this is what has been shown in the literature. So does anyone have any experience with using amivantamab in this setting, post osimertinib, Deepak?
So
Post osimertinib. It doesn't apply to our patients, but I'm just wanted to know the experience how with the.
I started in 3 patients, sir. Like this was off-label even before Mariposa 2 data came. With amivantamab was initially approved for the exon 20 insertions. I see response rate, the progression-free survivals to the tune of 4 to 6 months. Response rates again around half of these patients responding to amivantamab. I have not given a combination of amivantamab plus chemotherapy in any of the patients.
Any difference?
Just a comment and question on, and this is to the entire panel for Mariposa 2. Do we agree with the way this trial took all comers post osimertinib and did not screen for MET amplification or MET ILC? Because the way amivantamab works is by targeting EGFR and MET. If you don't select out those patients, how are you doing justice to your patient selection? And do you know the PFS difference of 4 versus 8 months is not that exciting to my mind. So should we select out those patients and then offer them amivantamab, or do keep it for all comers? And now post Flora 2 again, now this trial is now obsolete. So perchance if someone is only on osimertinib and they have progressed, do you give it to all comers or do you select out this is for everybody?
So very interesting point that Shikhar has told, sir. No, that's a very idealistic situation where MET amplification is quantified and we can initiate amivantamab. Definitely that's the group that would derive the maximum benefit. Or patients retaining the EGFR pathway, again amivantamab is an extracellular binding molecule, so would derive benefit. Problem with MET amplification or MET overexpression is the quantification and what is your cutoff point. Is the copy number value 5? Is the copy number value 10? Actually, across studies, that is the problem. We do not know what is the threshold beyond which we say MET is amplified.
Correct.
Yeah, so that is a problem with standardizing MET amplification per se to use amivantamab. I think probably that was one of the reasons why amivantamab plus chemotherapy was given across the population, irrespective of quantifying MET amplification.
The other issue is the assays for MET. It's not amplification. There are skipping mutations. There are many things which happen, but the space into which amivantamab came is probably irrespective of that, whatever the MET amplification or MET mutations are, in a situation where we have progressed on the standard osimertinib or EGFR, and then it's with the presumption that that could be one of the areas where we can target. As you said, if going into precision medicine, we may not be precise in doing that, but this is what it did, and this is what it showed, and I think having this as one of the options is not, it's not totally wrong, but I think there are several loose ends to be tightened. There was one more. This is this is case 3, last case. So 63-year-old lady, she presented in March 2022 with, of course, she has lung cancer, stage 4 lung cancer. PDL1 was 2 to 3% on by CPS. NGS revealed exon 20 insertion. So this is the typical case some of us may see in the clinical practice. So now how do we go about, we'll start from Dr. Asma. Either it's chemotherapy or?
Exon 20 mutation is present, sir. I go ahead with chemotherapy with osimertinib combination.
Any difference of opinion?
First line, chemotherapy only.
Following that, they don't do well with chemotherapy. We have tried afatinib in them, transient responses with that, or say osimertinib. They are all transient responses. They don't do well in the long run. After 3-4 months, they do progress in exon 20 insertion. So if and right now from the papillon study, we have got data from amivantamab plus chemotherapy is option in exon 20 insertion. So probably if the patient is willing, then we'll go ahead with amivantamab plus chemotherapy.
Sure. Shikhar?
Yes, I think the response rates with papillon are quite impressive, around 70-75%. PFS of around almost close to a year. So I think it is now the current standard of care for exon 20.
Agree, I think. So, but what happened is when this patient came, we did not have the papillon data yet in 2022. So what we did is there is some data on high dose, double dose osimertinib. So I don't know your experience.
Actually, the first and the third generation TKIs, I mean, even afatinib for that matter, works in patients having the short chain mutations near to the chromosome in the short chain arm. Predominantly the 763, 764 mutations in EGFR exon 20 insertions respond to the first and the second, third generation drugs. So actually, if we can see what kind of mutation, what exon 20 insertion the patient had, if it was 763 or 764, I think we can start with osimertinib or afatinib for that matter of fact.
Yeah.
There was a large there's only retrospective series in this data sets. And a lot of those patients had early progression. Those who were on first or second generation TKIs for those some particular sensitive exon 20 insertions. I think taking that chance is probably not, in the best interest, and we should give them chemo plus amivantamab.
Yeah, so similarly, some retrospective studies particular to this exon 20 insertions with 160 mg osimertinib, there are some 20-25% responses, but they are short-lived. That's what we did to her. She started on double dose osimertinib, but after 3 months, she developed the interstitial lung disease. But PET scan showed a good partial response, but we could not continue, so we changed to amivantamab based treatments. She had grade 2 infusion reactions, and on amivantamab she achieved a partial response. So this is about this case, and as you pointed out, the papillon, this is the papillon study data, which showed good responses and also numerically better, but statistically not significant increase in the overall survival, also with the combination of chemotherapy plus amivantamab. So we come to the conclusion. So we discussed 3 cases, one adjuvant, one metastatic with brain mets, and one with exon 20 insertions. I think the take-home message is that it's not one size fits for everyone. We have to individualize patients, each and every patient, and then explore options for each and every patient in a different way, probably which suits the best to them. And we, time is up, so done. And I thank all the panelists, all the audience, and the ICON committee for giving us this time.
Thank you, sir.